So hey, welcome. I'm Joe Smith. I'm the Chief Medical and Science Officer here at WestHealth. Thanks for coming today. What I want to do is welcome you to us, and then realize that the work that we're going to do today is probably not just going to be done from the podium, but it's from all of you. And so, additionally, thanks not just for showing up, but thanks for the work that we're going to do to kind of move the ball a little bit. We can't have a meeting without talking about the folks that make this possible. And so here at WestHealth, while we are a couple of different organizations all blended together, we really flow from kind of the inspiration and aspiration of Gary and Mary West, two successful Midwest entrepreneurs who have spent a life working very, very hard. In their work, they realized that they could control what businesses they built, what they bought, what they sold, but they could not in any way control the cost of healthcare for their employees and for themselves. And as they worked from really rather humble beginnings, they realized they lived the American dream, and that healthcare, the way we do it in this country and the costs associated with it, was a headwind for anyone else trying to live that American dream. That the process was was neither convenient nor actually sustainable, and that for their businesses, for their people, and for this country, they saw that the healthcare system that we have accumulated and now experience is one that doesn't serve and really is now a threat to our international competitiveness and perhaps even our national security as it threatens our economy. And so they set this up now about almost 6 years ago as an effort to make sure that high quality healthcare was more accessible to all Americans in a way which was financially sustainable. And so that's probably the end of a lengthy advertisement about the West. They're pretty private people, but you should know that the folks here are devoted. They come to work every day to try to make high quality healthcare more accessible and more affordable for all Americans. With any luck, this is a graphic that describes the problem. We're really good at spending money in healthcare. We're just not really good at making sure we have a sustainable program and platform for getting healthcare delivery to everyone. And you guys are at the front door of healthcare, right? You might even be in the driveway before the front door, right? So you're actually at times the folks on the wall who are helping individuals, but also helping to manage how those individuals get their care, where they go in the system. And so, and in many ways, for good and for bad, it starts and lives with you. And so we're delighted to have you here today, because if we don't solve this issue, it is not going to get better spontaneously. There are a lot of healthcare issues that you can say, well, let's see if it's still going to be okay in a little bit. We'll let you go. Given our aging demographic and how much we spend on healthcare and the challenges that this country faces that are unrelated to healthcare, where we need those dollars, you can think about an aging infrastructure, you can think about our defense needs. This problem desperately needs to be solved, and it won't solve itself. The Commonwealth Fund did an interesting study to look at the 11 OECD countries and figure out how are we doing in terms of the quality of the healthcare we provide and the dollars it costs us to provide it. And good news is we are number one on one of those axes. We are the most expensive healthcare system in the world. The bad news is that we are at the bottom when it comes to quality, that you might measure in lots of different ways. You might look at it as overall longevity. You might think about it in terms of infant mortality. Lots of different ways of thinking about it. No matter how you do that, we are not the best. And in many metrics, we trail 30 or 40 countries in some of these metrics. And so the opportunity here is enormous. I mentioned that we are 4 different organizations. So you're in a medical research organization called the WestHealth Institute. We also have a policy center in DC, because I think it took them about 30 seconds to figure out that it doesn't really matter what you do in terms of innovation and research if there isn't a conducive public policy environment. We also realize that, as it turns out, we're not the smartest people in the world on this. There are others who are working on this issue as well. And so that got us to think about how to propel other people's efforts. And so for that reason, there's a mission-aligned investment fund. So we will put money to work on other people's ideas in their businesses to try to achieve the same goal. And then lastly, we have a small business incubator, which is for like-minded companies that need help getting started. And so we have that as well. What do we mean by high quality, accessible, and lower cost? Well, lower cost, I think you can all figure that out, right? So, you know, if the coffee's cheaper at one place for another, you can kind of go there if it's the same coffee. But high quality is kind of an interesting concept, because we in healthcare haven't really agreed what quality is. We have quality measures. The National Quality Forum gets together and talks about quality measures for hospitals or for providers or for services. And there's fair disagreement. I think quality for some is like pornography. You know it when you see it. But in healthcare, we have an issue with the transparency of healthcare quality. Most people experience the systems of healthcare delivery through a lens which is not identical to others. And so for some, it can be, my doctor listens to me. For some, it can be, it was really easy parking and the food was pretty good. For some, it would mean that the lighting in the hallways was pretty clear and I got to see my family whenever I wanted. And so there's been a drive afoot in Washington to make sure that we only pay for quality, that we look for quality outcomes. And I think we owe it to ourselves to be clear about what those are. I think from your perspective, I think quality may look a little bit different yet. You know, the notion of rapidly responding, giving best possible care in the shortest possible time, and getting people to adequate facilities may be a measure of quality. But overall in healthcare, this is an ongoing discussion. We don't yet have definitive answers. And then accessibility. What does that really mean? For some, it means I can get to a doctor within a finite amount of time. For others, it can mean, you know, I don't need to have a doctor because I have an emergency room. And for some, it can mean really what I want is relevant information at my fingertips. And so give me the information. I don't necessarily need to spend the next 8 hours in an emergency room if someone could tell me that what I have is benign enough that it's going to get better on its own, or I could go to a CVS and get what I need, or I can go to an urgent care center and get taken care of that way. So that notion of accessibility relates to accessibility to the appropriate level of care, not necessarily accessibility to the maximum available services. And so we're in the middle of a national discussion about that. We have got to get that right, because clearly if everyone wants accessibility to the maximum level of services in an instant, that's a system that we've seen and we can't afford. And I could tell you a little bit more about us, kind of the work we've been doing. We've got a lot of things on our plate, and if this looks like a plate to you, then maybe that's right. But so we spend a fair bit of time talking about interoperability. It's a complex 16-letter, 8-syllable word. But you know, for those folks in EMS and fire and emergency response, you know that not all the systems always talk to one another. You know that sometimes across services you don't really have meaningful communication. Now imagine that in healthcare, wouldn't it be great if everything that was done at one location would be available and integrated into what is known for a patient when they arrive somewhere else? And so that is an issue that's pervasive. You know, I was on a flight back, sitting next to a fellow at the DOD, and I said, you know, you guys have to manage lots of independent services. How do you make sure that when there's a threat, everybody can share all of the information? And he confided in me that, you know, sometimes what that looks like is a phone call where you tell one service tells another, you know, some abstracted notion of what the information is. And when you've got complex situational awareness and your best form of communication is voice, I think you're missing some of the richness of information. You guys have some of these same struggles, right? So if there's a fire and someone calls 911 and says a fire, if they had video and could show you what that fire looks like, you would know better what services to send. Or there's an automobile accident. If there was if you had rich multimodality communication around that accident, you would know what services to deploy. We're well shy of a world where that sort of information flow is as wide and as fast and as deep as it needs to be. Our dog in this fight around healthcare is that for patients that get services at multiple sites, the information available to make sure that the best care is given is often much less than what could be available. And in complex settings where you have many devices around and working on a critically ill patient, those devices seemingly never share information. And so it would make perfect sense if you're a sick person in a hospital or an intensive care unit and you're getting, say, drugs you guys are familiar with, right? You're getting morphine for pain and your breathing starts to slow. Wouldn't it be great if that pump that was giving you morphine slowed down or stopped because your breathing was slowing or your blood pressure was falling? That natural interdiction of activity, it would be great if that happened. We don't have any of that today. And so we're pushing for that because a smarter learning healthcare system requires kind of the seamless and unimpeded flow of information. And so it's one of the things we push on. We've asked nurses to tell us, hey, when you're busy working, if this worked, almost does. Let's see. Yeah, there we go. When you're working on sick people, does it matter that information isn't flowing from one device to another? And overwhelmingly they say, look, it's a source of error, it's a source of confusion, it's a source of delay. I didn't go to nursing school to take care of equipment, so help me out. So we're trying to do that. We're also recognizing that it is important to try to move data more than you move people if there's an opportunity. And so I'll give you an example. Over here, we've spun off a company called Reflection, and their effort is to make sure that for people who are recovering from joint surgery, from people who are struggling with post-operative rehab, we can do all of that at home. We can give them examples of the behavior that they should have and then measure them against it. And so we do that. When we look at the onslaught of autism and what's happening in this country with, maybe 1 out of every 65 or so kids is diagnosed with autism, and we've got to describe a way of giving them behavioral therapy at home when it's going to cost maybe $80,000 to $100,000 a year, and we're going to do that for 1 out of every 65 kids in this country. That's another thing we can't afford. But perhaps we can make this something that, if by just moving data, by just having integrated smart systems where the kids can get this at home, we can save an awful lot of money and help an awful lot of kids. And so that's something else we're doing in a program we call Immersive. We've spent a lot of time developing a strategy we call WestTech, which is really, can we measure biometrics around chronic disease in patients who have them? Imagine blood pressure. Can we measure your blood pressure every day at home? Can we titrate your therapy, not every 6 weeks or every 6 months when you're about to see your doc, but perhaps when you need it? Much like when you fill your gas tank because it's empty, wouldn't it be great to change your therapies based on how sick or how well you are and not based on some schedule that's related to a doctor's availability? So I could go over all of these. I don't necessarily want to, and you shouldn't have to sit through that. But if you believe in this notion that we need to democratize and decentralize healthcare, to make healthcare accessible, perhaps not emergency room care as immediately accessible, because there's emerging data that actually a fair bit of hospital care is more harmful than it is good. But if we can make meaningful, appropriate healthcare available by moving data or moving services and not necessarily moving the sick person, maybe we can help. And so, as we've done this work for the last 5 or 6 years, we've come to realize that there's a natural focus for us that perhaps we were attending to, but not necessarily focusing on. And that's the notion of most of this is an issue for seniors more than for anything else. And so as we've worked through this, we've said, you know what, it's not just about making sure that care is more automatic, more connected, more coordinated, that systems share information with interoperability, that we make healthcare more accessible and more affordable, but it's also giving us focus to say it's more about seniors than it is about anyone else. We have an impressive problem with an aging demographic as we look forward, where chronic diseases accumulate and where we spend money in both healthcare broadly, but also in Medicare. We're spending it dominantly, even up to 95% of the dollars we spend, depending on how you view it, is spent in seniors. And so let's focus. And so we have a new dedicated focus around successful aging. And what we mean by that is for folks, for seniors, and we'll pick a number. AARP starts sending you ads when you're 50. We'll say 65 because that coordinates us around Medicare as a payer. And we'll say, look, you know, if we can make healthcare so that it's more comfortable for you, it's easier for you, it's more user-friendly, and at the same time we allow you to have the ability to stay in your home or in the living circumstance of your choosing longer, so that you don't have to be struggling with the many transitions that folks have as they age. If we can make healthcare more accessible and more affordable and more sustainable for you, then we're going to solve a problem that is facing the country. You know, when you look at the economic burden of aging in this country, it's dominantly around healthcare, and actually California is a relative spike in that. You know, for some reason, folks, once they age, they want to live by the coast, and they come here. And so we have to solve this problem for us, we have to solve it for California, and we've got to solve it for the country. And so we're going to bring all of the tools we have, which are some but small compared to kind of the tools that you guys have, to bear on this. How can we make it easier for seniors to age respectfully, gracefully, more comfortably, and more successfully? And our dog in this fight is making sure that their health care is accessible, affordable, sustainable. And so we're going to bring together all of the organizations that we have here on the nonprofit side, but it's also clear that the Wests have some for-profit businesses we are going to learn from. And so there's a great West Living, which is the notion of senior living facilities. We're learning from them. The West Foundation has put up the West Senior Center downtown, which serves 900 to 1,000 folks meals every day, and this notion of how can we do well by putting, at that point I think I had 26 nonprofits all co-located in one facility to help largely homeless seniors do better and avoid out-of-pocket hospital, out-of-pocket healthcare costs, but healthcare utilization in general by wrapping around social services. And then the last bit of this was we just got approval for, and Shelley Lyford, who is not in the room, is pioneering setting up a dental clinic for homeless seniors down by the West Senior Center. For those of you involved in healthcare, you realize that the big gap for seniors is often dental and mental, and so we can start to address at least the dental part of that this way. Anyway, this is today's agenda. I've given you a kind of a lengthy and relatively disjoint presentation with the hope that you would see that it is really all coming together. That we've done a lot of work over the last 6 years in many different parts of healthcare, but as we sat back as recently as a couple of months ago, we said, you know what, it really is about successful aging. It really is about our senior community and all the work we can do. The work before you today is much and varied, but the challenge we face in healthcare is enormous. To try to bring this beast of an offering that we provide in this country that consumes nearly 18% of our GDP, to try to bring that down to something that is better for patients and yet economically sustainable is really the challenge before us, and it's not going to get better on its own. So you've got to play a big role in helping us to get this done. And as I said at the beginning, you really are the front door to this, right? So it is emergency services, it is community paramedicine, it's first responders. How do we make sure that what we provide is appropriate, is high quality, and is ultimately sustainable? And so thanks for being here to have this ongoing discussion with us. we'll do what we can to help, but clearly we're going to be mostly in a listening mode today to understand how we can best catalyze the change, and we'll be looking forward to seeing what we can do to make this an affordable, sustainable, high-quality healthcare system for all, importantly for seniors as well. So I'm going to then give up the podium to my namesake, Noah Smith. We are not related, just so you know. And so thank you for being here today. Noah, thank you for coming, and let's get the day going.
Thank you very much.
All right.
Appreciate it. Good morning. How is everyone? Good. It's my first time in San Diego, so thank you for having me. My name is Noah Smith. I'm an EMS specialist with the National Highway Traffic Safety Administration, Office of Emergency Medical Services at the U.S. Department of Transportation, which is one of the shorter titles in federal government. I must thank Dr. Smith and the WestHealth Institute for hosting us today and for your continued partnership with EMS and with the first response community. Doctors Munjal and Dunford and the great teams at Mount Sinai and UCSD for their leadership in this project. And of course, my colleague Ray Mollers from the Department of Homeland Security, who will speak in a moment, and our partners at the Departments of Health and Human Services, who are managing this project with us as well, who could not be here today. This is really an innovative and historic undertaking. This is national organizations, state organizations, academia, government, regulators, local healthcare providers, private industry, all coming together for pretty much the very first time around a singular goal, which is improving how EMS responds to and improves the health of their communities. And what's even more incredible, for those of you who have spent any time in Washington, is that 3 federal departments have actually come around this topic as well to co-manage and co-sponsor and co-fund this project and this series of meetings that we're hosting. And that's because we really believe in the incredible potential that EMS has to improve healthcare systems in ways that we probably haven't even thought of yet. And there are a lot of jokes, I imagine, that we can make about Washington. You've probably heard a lot of them. But the truth is that when it comes to EMS, we're actually doing pretty well. Agencies and departments coming together to co-sponsor events like this is not actually that remarkable. We actually even have a formal committee that has been set up and authorized by Congress to do exactly this, to co-fund and co-sponsor projects of national significance. It's called the Federal Interagency Committee on EMS. Everything needs an acronym in Washington. It's called FICOMS. It has representatives from 10 different agencies, and we recently published our first ever 5-year strategic plan. So to put some perspective on this, you got 10 federal agencies to come together around 30 objectives to support emergency medical services in the United States, which I think is pretty remarkable. And one of our main goals is to promote EMS systems that are sustainable, forward-looking, and integrated with the evolving healthcare system. And one of our objectives to do that is to foster and evaluate the development of innovative delivery models for EMS systems that could lead to changes in reimbursement. There are a few important words in that sentence, but the one I'll focus on for a moment is the word system. The National Highway Traffic Safety Administration, some of you may be looking at me and saying, why is transportation here? That's a very good question. NHTSA, as we're known, has promoted a systems approach to the improvement and development of emergency medical services since the 1960s. And in fact, our very first leader at NHTSA was a physician named Bill Haddon, and he really recognized that EMS plays a life-saving and obviously very critical role after a traffic crash in saving the life of somebody who was a victim of that crash. But he also recognized that an EMS system cannot be only good at responding to traffic crashes, they have to be good at responding to everything. And hence was born the modern EMS system and the support that the Department of Transportation and its federal partners have been giving for about 45 years now. And we know that EMS systems are undergoing significant change, and there is an evolving national healthcare. The national healthcare system is evolving, largely due to many of the problems and money that Dr. Smith just talked about. But the Affordable Care Act and many other things have encouraged a lot of innovation, including the increase of EMS workers in non-emergent community health and other roles. We know them as mobile integrated healthcare or community paramedicine. I imagine we're going to talk a lot about that today. But there are many other clinical, financial, operational innovations that are going on in EMS that is not just community paramedicine or not just mobile integrated healthcare. We have been following innovative models to decrease the costs incurred by unreimbursed transports, to decrease the burden on transport ambulances, to increase primary health care in shortage areas, both in rural and urban areas, to improve community resilience, which is incredibly important. And then in just sort of other ways to enhance the health of a community, particularly innovations that we actually haven't even thought of yet. And that's why this project is not called Promoting Innovation in Community Paramedicine, but is called Promoting Innovation in Emergency Medical Services. It remains intentionally broad to encompass all types of innovation, big or small, clinical or otherwise, and like I said, even things we haven't even thought of. The project that we have funded and that this meeting is a part of is going to assist state and local EMS systems to innovate by developing model, legal, regulatory, and financial frameworks that they can then implement to encourage the testing of new models. And state oversight is going to remain a very important part of that, and we thank our state regulatory partners for being here today. State oversight of demonstration programs and of all programs helps to ensure consistent quality, safety controls, medical direction, data collection, comparative analysis, and eventually financing. Several states like Minnesota and Maine have taken legislative action to address their statutory framework in response to some of these emerging innovative programs. And of course, right here in California, you've done something very similar to foster, I think, nearly a dozen community paramedic pilots, and we're going to hear from many of them today, which is very exciting. But in talking to several folks from this state and from other states and from folks who have been working on pilots across the country, I know that that is not an easy process. And the thing is, it should be. It should be, and that's what we're trying to solve here today in California and in every state. Some of the questions that we've heard when we go around the country and we talk to people about some of these innovative ways of delivering EMS or just mobile medical services, the E is increasingly becoming less telling, is that are questions like, is the traditional role of EMS medical direction still pertinent as a provider is engaged in public health or community health or chronic health management? Is the scope of practice of an EMS provider sufficiently flexible to accommodate variations in practice to test innovation while not harming patients? Is the authority of the regulatory or oversight agency still sufficient to authorize and oversee innovative projects and to translate promising results into sustainable system enhancements? And what laws, regulations, and policies at any level, including the federal level, state, regional, LEMSA, and otherwise, must be amended to better foster innovation while still protecting the public's health? So learning lessons from states like yours and from states around the country that have encountered these issues, that have tried to answer these questions and other challenges, and then sharing them with the national community is what this project is all about, and it's absolutely critical. That's why today's conversations are really exciting for us. We really look forward to the conversation and to partnering with you moving forward. So again, thank you very much. If there's anything that we can do while we're here or in the future, we're more than happy to help. Hopefully you see that we're pretty open to sort of talking about whatever you want, but whatever is certainly most helpful. So thank you very much again to the WestHealth Institute, to UCSD, and to Mount Sinai. And with that, I'll throw it over to Ray, I think, to provide some comments from the Department of Homeland Security. Thank you so much. Enjoy the day.
Thanks, Noah, and thanks for hosting us. As a partner of FICOMS, the Federal Interagency Committee on EMS, we are interested in this activity, not just from growing EMS and looking at where we can go in the future, but also from the Department of Homeland Security perspective of what can we do day to day to get that better care and that care sooner, get it to the places that need it in different ways. And in doing that, if you're doing it on a day-to-day basis, you can do it in a disaster easier. The federal government, especially FEMA grants, they're coming down. Those dollars are drying up. Even from a perspective of critical infrastructure, emergency services, some of them are just, the innovation might be what's just keeping them alive. You know, it may have been grant dollars that created a capability through either purchasing equipment or creating some sort of program, but the sustaining dollars are not there. So we need that innovation to keep those capabilities going, keep those services alive. So that's kind of our perspective. We're really in the learning mode, and we're real interested in where this goes. We think community paramedicine, mobile integrated health, we're not quite sure what it is as a nation, where it's going, what we need to do, but we do believe that it is part of the innovation, and we need to foster it and to learn from it and to promote it. So we welcome you. We thank you for having us, and please let me know if you have any questions from the Department of Homeland Security perspective. I'd be glad to talk to you. Thanks.
Good morning, everybody. I'm Jim Dunford, and welcome to San Diego, although the majority of the room is from San Diego. And that's not just because we're such good innovators, but we are. So, first of all, you know, not to make this long and drawn out, but we really do owe a debt to WestHealth. We've actually had this wonderful relationship for the last few years. Believe it or not, the last couple of EMS fellows at UCSD were actually WestHealth fellows. And it's been a wonderful relationship where we've begun to understand the bigger picture of EMS as we've worked with West. We hosted a summit here about a year ago on Next Generation 911, which was very interesting, just looking at the communication opportunities in the future when everything really is broadband, text-based, and the 911 system of the future is going to have expert input, and you know, police, fire, EMS, and everything is really all going to be one great big integrated CAD. And you start thinking about the data potential and the opportunities and the regional surveillance and the homeland preparedness and the entire spectrum of what's coming. And that just gives you a taste of the kinds of things that West is actually interested in, and which we all, I think, understand, you know, is something in the future that we're going to be able to bring to a system that is today the EMS system, but tomorrow is this EMS agenda for the future. For those of you that don't know what that is, it's 1996, you know, when the federal government first actually started seeing what EMS could add to a healthcare system. And this document has been standing out there really waiting to kind of get put into place. Our document that will be the result of this 2-year effort of what we're doing here and in New York and then iterated over the next year and a half is ultimately to be a report to the federal government that says this is what EMS can do, these are the barriers, you know, here's what we're doing today, these are the bright ideas in New York and, you know, in Arizona and Nevada and California. It's all going to get put together in a great big report, and then there's going to be another EMS agenda for the future, most likely, that's really going to finally push this thing home. I think that would be one noble goal that we all kind of have. And intent to do, because there's never been a better time to do it. By the way, I'm going to back up and say the people here locally that have been really great. Joe obviously is always great. He's a wonderful spokesperson for everything. But Dr. Chris Crowley is a systems engineer, and if Chris is out there, he has been phenomenal in terms of being able to start to integrate us, and his logic is just beyond a reproach. It's amazing. I've never met anybody who thinks with more clarity. Now, the other guy that in the room that obviously we couldn't be doing this without is Kevin Munjal, Dr. Kevin Munjal, back there in the back. And Kevin and I first became friends a 3 years ago at a National Association of EMS conference when he had just published an article in the Journal of the American Medical Association that pointed out that without financial reform of EMS, we're not going to get any place. And the entire predicate of being paid to take someone to the hospital and that's it really was just not the way to do it. And when he finished his MPH at Columbia at the mailman school there, it was all about the financial drivers of EMS and why this has got to change if we're really going to do something more effective. his partner and the project director is Hugh Chapin, and Hugh is right in the back here, and he's just been fantastic in some of the things that we've done already, particularly in terms of telephone surveys, some of which you guys have participated in. But we've been canvassing across the country trying to find out issues about how people feel about innovation and where we're stuck today. And you'll hear some of that this afternoon when Kevin actually does a presentation of the initial information. Our other local dignitaries include Bruce Haynes and Marcy Metz, who are our county EMS authorities here in San Diego, and I want to thank them too for actually participating today. Where I go back on this whole thing, there was a meeting here out in Laguna Niguel a few years ago, and at the time there was a guy by the name of Mohammed Akhtar. And Mohammed was a physician who was the medical director or executive director of the APHA, the American Public Health Association. And he was going around the United States saying public health is basically so siloed and so, pardon my French, we have to connect. I heard my wife's voice in my ear. Thank you. He was reaching out to, yeah, there we go. He was reaching out to everybody from the AAMC to the American Nurses Association to EMS physicians, the AMA, everybody, and saying, you know what, we cannot do this. We are just insulated, and this is so wrong. Who'll come to Washington and start to discuss the conversation of EMS? How can we link in EMS? And began this process of trying to make us part of a more integrated system. And it really, the EMS agenda for the future is more of the same. And I think that's really what we're back on target. Unfortunately, 9/11 kind of knocked our pins out from underneath us, and that whole momentum to integrate was lost in a much more complicated set of issues. But it really provides a wonderful example of the ways that things did to begin to integrate. Tragic as it was, law enforcement and those communities began to talk on a common platform. Today, the next platform is about to evolve, and that's the social information exchange. It's the world of the patient and what they like and how we have to exchange that information too. And if anybody knows what people are in and where the mistakes are and the problems, it's the people in the homes. And that happens to be us 120,000 times a year in San Diego City alone. And so there's this incredible opportunity to start to mine information, see what's really going on, and come back and ultimately say, this is what has to get fixed. Last week, Dr. Ted Chan, who's the chairman of emergency medicine at UCSD, and I were at a dinner. The dean of the medical school was there, and some of the physicians actually having a dinner together, and one lady got an award for this wonderful project she does on brain tumors. And she's working with adolescents with brain tumors. She sat down, and I said, gosh, that's fantastic. What do you do? And I said, well, you know what? I'm the city medical director. It seems like all I do is take care of homeless things these days. That's my #1 problem. She said, oh, I've got this horrible situation. I've got this wonderful young man downtown with this terrible brain tumor. I've got his chemotherapy. I've got his radiation therapy. It's all lined up right over here, but he's homeless, and he has no ride, and he's not coming. He can't get his treatment. Okay? Now, you can have the most brilliant minds, you can have the most brilliant hospital systems, but if you don't have a car to take this kid there, the healthcare system is completely broken. I worked my last shift in the emergency room. We admitted a guy after 5 visits to the emergency room. He's out here in San Diego visiting. He's got some issues to deal with. His blood sugar was 600 5 times in about 20 days. Could not get that guy's diabetes managed. He had never been on insulin. In the hospital you come. Very wasteful, unbelievably approachable if you had the right systems in place to be able to build something for this guy. So when you start thinking about what can we do better, it's just everybody knows. You know, my interest in this thing is I feel like all roads to brokenness lead to the emergency room. And UCSD being the magnet of them all. And so how do people get there that are really broken? They call an ambulance. Not because they got hit by a car that moment, but because they don't have a car or the air's out of the tires, right? So the super subset of problems, in fact, is really defined by who's taking ambulances to the hospital. and because those systems of care have really deteriorated. So we become this tracer condition for a much broader set of issues that people have never really looked at before and go, wow, EMS actually really is a benchmark, kind of like the way the wind blows on top of your sailboat. It's telling you where things are going. Without too much more about those issues, the goal here ultimately is to come up with systemness. And that's what we are. We're the grand central station for a whole lot of stuff, in the same way that emergency medicine is. Kind of like, you know, we're supposed to be experts at everything. And I think EMS is going to have to grow into this role. It's a fascinating role to become. But these interdisciplinary projects that you see, like what our co-sponsors are, Homeland Security is interested, Public Health is interested, Health and Human Services is interested, in all of this array. So as we talk today about culture and the other things, everybody's got a view. Are we really the paramedics that are going to go into the warm zone for active shooting and we actually wear bulletproof vests? Or are we going to put a white coat on and we're going to go over here and take care of grandma and get that pillow nice and fluffy? You know, how can we be all things to all people? Well, in a way, if anything can, EMS can, by virtue of what its inherent rules are. And what our mission is and what our opportunity really is, because nobody fits this space quite like us. But I think a lot of people don't know anything about EMS. You know, they really still picture us as something out of the television series, and they don't understand we don't have a single measure of quality, so nobody pays us for nothing but taking to the hospital, so how can we prove anything? I've been at the National Quality Forum for 4 years now, looking at the measures of care for the dual eligible population. There's no EMS measure. There are hardly any emergency medicine measures. So how in the world is the Secretary of Health going to say, I want to buy that and I want to pay for that because that got me quality, when there's not a single measure of EMS? So we've got a lot of work to do to understand how the world really works. EMS does. But it's very doable. All right, I just saw my favorite doctor. Dr. Nick Efantides is going to roll up here right now. Dr. Nick is going to come and give you the last 3-minute welcome before we start our day. And let me tell you what we're going to do right after. Well, actually, this is Dr. Nick Efantides is the Chief Medical Officer of San Diego County.
Thank you.
We are behind schedule, so I'm going to say the shortest welcome you've ever heard. Welcome.
He's got more in him than that, I'll tell you what. Okay, so the way we're going to begin this morning is with examples, because I think everybody wanted to hear something about what was going on, and it's a combination of addressing two topics. One is really good ideas and what's in the way of making them happen on a local level. Not naming names, but concepts. What do we have to fix here? Because what we want by the end of the day is we want a list of prioritized items that say, how can we make these things go, but what do we have to do to fix it? And the fix could be any of those barriers that we'll be describing, along with what partners and who else do we maybe need to do this with that we haven't really considered before. For those of you outside California, you may or may not know that the state of California EMS Authority, and where's Dan Smiley, because he's an extremely important poobah amongst us here. Dan is actually representing the state of California EMS Authority, and they had in their wisdom, I really mean 2 years ago, an idea to really explore community paramedicine in a way that no other state was doing. Before we got there, the California Health Foundation had come up with a little bit of money, and they hosted a forum at UC Davis to explore the possibility of community paramedicine, and it was pretty much unanimous. And we had Medi-Cal's medical director there, and we had everybody come into the room to say, gee, this is an interesting idea. From that, there was essentially an RFP that was kind of issued, request for proposals of good ideas. And the state ultimately selected 12 that they thought would represent a cross-section of the community paramedicine pilot ideas, and now have been moving this forward. And Lou Meyer is the coordinator for that, and Lou's here today from Sacramento as well, who has been diligently coordinating how we are going to be measuring these data from each of the 12 sites. The University of California, San Francisco has been hired to be epidemiologists and investigators. Each of the counties have been working diligently. We're all trying to get IRBs through our respective universities. And ultimately, we'd like to roll this thing out. 200 hours of education have already been done. After selecting a core group of senior, mature, top dog paramedics, we've got a bunch here in the room today, but at the end we wanted to hear from the 12 programs. So what we're going to do is have them do lightning rounds. So we're going to go through the 12 programs, if everybody's here, I'm not sure, talking about what are we trying to do and what's in the way. Then we'll take a break, and then we're going to come back with 6 more good innovative ideas that aren't community paramedicine related, but have to do with the ideas and the challenges of innovating in EMS. And then there's somewhere in there's a bathroom break and there's lunch, okay? So why don't we get rolling? Who's first up? Unfortunately, I don't have the agenda.
So the alternate destinations, there's San Diego EMSA.
Okay, so that would actually really be the Carlsbad project. Because we're going by the local EMS authority, and we're just picking, we kind of aggregated them into themes. So thanks a lot. Come on up, introduce yourself, and we'll get ready.
And I'll wait from the back when the time is to wrap up.
5 minutes? Maybe not even get that far, 2.5, 3. First of all, Josh Clark, Carlsbad Fire. Just want to thank everybody for having us and the ability to be part of such an innovative thing. I mean, obviously, alternate destination is just one of the 12 things that we're doing here in the state. I do want to say probably the most innovative thing is rock, paper, scissors, because I've realized that all equality comes from rock, paper, scissors, and that's why I'm standing before you at this very moment. There's nothing that seniority, arm wrestling, none of that works. Rock, paper, scissors. So at the end of this, if we could just do rock, paper, scissors, I think all decisions can be made in legislation. We'll fix not only community health, but also worldwide hunger and homelessness. So thank you. First of all, alternate destination. I mean, I think we all know a little bit about it, but just to kind of review what that means. For us, we're public servants. We're looking at the citizens of our communities, our state, and our nation, and getting them at the right place at the right time. Currently, our current program is we transport to the ER. So if somebody calls 911 in their worst time, none of these people call 911 because they want to have just a friend or a foe to talk to or kind of talk about the daily news or the upcoming elections. People call us because they have a true emergency and they don't know what else to do. So they turn to us, whether it's, grandma has a heart attack, somebody has a snake in their yard, somebody's trying to figure out how to install a smoke detector, or simply change a battery in order to stop the incessant beeping at 3 o'clock in the morning. We respond. And as Dr. Dunford kind of said, we're basically the people that take care of all these problems, that there isn't really a management company or anything that really ensues from that. So with that, we do not only specialty care on a day-to-day basis, but we also do low acuity, and that's where we kind of intercept the ability to take to alternate destinations. Right now, we currently work under doctors, nurses, Health and Human Services, the state, the LIMSAs, county health. We work under everybody. We have a strong education base. I mean, if you look at education for being a paramedic, I mean, not only are you looking at starting from the bare bones, doing CPR, working up into being emergency medical technicians, taking advanced skills, learning numbers of medications. I mean, not to the level of being doctors, but definitely the basics of life-sustaining treatment. And we have well-identified protocols. Definitely something that we take wholeheartedly is understanding those protocols, knowing how to take what the patient says to us, critically think, and make decisions in split second. There's definitely not time to sit and research, so that's where all of our education comes in making split second decisions for these patients. Right now, our program, we want to keep people in their healthcare home. Basically what we want to do, and Kaiser has been the one that's kind of got on board with us here in Carlsbad, and I won't speak on behalf of the other ones, but they kind of agreed to say, okay, you have a patient that is a Kaiser patient, low acuity patient. What we want to do is we want you to call us, interface as you normally do on your day-to-day calls. You talk to a doctor in the Kaiser facility. That doctor, after you go through your protocol, has the comfort of saying, yes, please bring this patient to our facility. The patient is a Kaiser patient already being treated here. We know all the medical history. There's no need to have an interface. There's no information that has to be brought from the home. It's all there at the hospital. That patient could get proper care for whatever their injury or ailment is, and then they could be discharged without being moved around the system as we normally do, which, as we all know, is basically driving up costs, as we notice here in this morning lecture. So essentially what we're looking at is the right patient, the right place at the right time. So our goals, as with most of them, are being responsive to the healthcare changes. Our world is constantly changing, and EMS, every day, we don't show up and have a specific schedule. We definitely have a schedule of training and the basics of what we want to do, but we don't know who's going to call or when they're going to call or what they're going to call for. So basically, we have to have all this education, funnel it down, and when we arrive, we have to not only take the dispatch notes, but also what the patient's saying to us and use our critical thinking in order to treat appropriately. We brushed off it a little bit, but we're adopting the Affordable Care Act triple aim. So we want to increase the experience of our patients by taking them to the right facility, keeping them within their healthcare home. That'll also decrease costs by not transporting to a local ER, and then also then taking them to a low acuity of their own choosing, whether it's Kaiser or Sharp or whatever other medical group we have out there. And then we're also going to improve the health of the population. You know, we noticed here we're definitely spending lots of money, but we're not being efficient with our funds, so to say, as far as the outcome of the health. What we're not doing is changing the health care system. We're just reallocating and improving patient care. We're not changing the people, the faces, the names. All we're doing is figuring out exactly what we want to do with all that information and provide health for not only all of us, but the people that we care for. Overall, some of the barriers that we have is just trying to get the education, critically think for ourselves and for the people. Solutions that we have, what we want to do is assure patient safety. The patient is the first and utmost importance. We want to have competency of our floor personnel, and we want to have outside validation. That's why we bring in all of you to validate the things that we're doing on a day-to-day basis. What we can do to change our success, nothing specific. I think one of the best things that I've heard in a long time was the mantra of Phoenix Fire, who I think is pretty innovative in the healthcare EMS fire-related. Prevent harm, survive, and just be nice. Thank you.
So by not showing up, the rest of Los Angeles County is the unfortunate consequence that I'm representing them. So I'm Ben Squire, I'm the medical director.
I just want to reiterate to everyone, make sure you try to spend at least some of your time focused on what your challenges are, what you're struggling with.
Definitely. So I'm Benjamin Squire, I'm the medical director for Pasadena Fire, and we're one of the alternate destination sites, very similar to the Carlsbad project that you just heard about. The concept is very simple. We're going to take patients who call 911 who have a relatively simple complaint. The types of complaints that we're focusing on would be acute back pain, an extremity injury without severe deformity, simple lacerations, nausea and vomiting without abdominal pain, really kind of lower acuity motor vehicle accidents where people don't have evidence of serious injury. We want to see if paramedics can identify this subset of low acuity patients that could be safely transported to an urgent care center instead of an emergency department and be safely cared for there. One of the requirements we have for our project in LA County is that the urgent care centers have to accept every patient brought to them regardless of payer status. So they're subject to requirements very similar to EMTALA. They can't do financial screening or take only patients from certain insurances. And I think that's one of the key aspects to our pilot program. We'll talk about benefits and costs. So what are the benefits? To the patient, it's very hard to identify any real benefit. The patient should be getting the same care, if they're selected properly, should be getting the same care in an urgent care center as they would in an emergency department. So what's the benefit of the patient to going to the urgent care center? So if the emergency departments are overcrowded, which often they are, there's a theoretical benefit that they might be seen faster. Now, this is a problem that could be solved by an alternate destination plan, or maybe our emergency departments just need to increase their capacity. And maybe that's the solution that we're looking for to this problem. The cost to the patient likely won't be much different. The cost to the payer would be less. Going to an urgent care center is a much lower facilities fee. And this is one of our challenges also, looking at how this program is going to be paid for in the future. If the payers are the ones that are getting the cost savings, then how are the payers going to help to fund this program? There are costs to this program. There's certainly training and startup costs to the fire department in training our personnel. There's also a cost in that currently there's no mechanism for reimbursement of ambulance transport to an urgent care center as opposed to the emergency department. So the fire department stands to lose some money transporting patients to the urgent care center, which may not make this sustainable in the long term unless a solution is found here. Another challenge is the educational aspect. So we have about 160 field personnel in Pasadena, which is, a small to medium-sized fire department, probably pretty similar to Carlsbad. In order for this program to work, every single field unit has to have at least one member, and preferably all of the members of the care team have to be familiar with these community paramedicine triage protocols. We can't put all 160 personnel through an 80-hour course or a 100-hour course. So how are we going to get this level of education into our field members in 8 to 16 hours? This is certainly going to be a challenge to us. I know I started off my career as a paramedic. I received excellent education in resuscitation. When I was a paramedic, I could run a medical resuscitation or a cardiac arrest better than most doctors, even better than a lot of emergency doctors. I really did not know that much about low acuity complaints. I received very little education there. This is what my medical school education and my residency taught me. As an emergency physician, you learn to differentiate what are the subtle presentations that could be sick or not sick. And so a major challenge is how are we going to educate our paramedicine staff into this very complex decision making. So I think that's all my time. That's our project in a nutshell.
Speaking to some challenges hitting the Orange County.
Well, good morning, everyone. Tony Copley, I'm the fire chief for the city of Fountain Valley. I'm here representing the Orange County pilot project that is sponsored by the Orange County Fire Chiefs Association. So I'm going to do something a little bit different than the other pilot projects that came up and spoke. And I'm going to speak more from a fire chief's perspective, not more like a very technical medical perspective. So forgive me if I stay at kind of a 30,000 feet a little bit. When you talk about challenges, my co-partner, Kathy Ord from Newport Beach Fire Department, and I were sitting at the EMS meeting, or we have a monthly EMS meeting that's sponsored by the fire chiefs. And we saw that there was this opportunity to participate in this pilot study. And I thought, oh, this is great. This will be easy. Let's just, our medics do this daily. They triage people that are critically ill. This will be simple. Was I wrong? 30,000 foot level thinking, right? So now I'm down into the weeds. I can tell you exactly what an IRB is and what it takes to get there. We're not quite there yet, but I had no clue what that was going into this. Significant challenge. You take someone from a field, a very operational level, and you look at, like, this is simple. I take someone that's got a broken arm and I'm gonna run them over to the UCC. What's the big deal? There's all this other stuff in between that happens, and those are the challenges. Those are the hang-ups with this whole thing. And that's why I'm just so thrilled to see all these technical experts in here. They're gonna figure this out for us. So that is really what we did right from the very beginning. We looked into the community, we looked out into the people that we serve, and we made partners early on. And one of those, the very first stop, was the local union group. And within Orange County, they have what's called a UFOC group. And it's all the union groups, and they come together and they meet and they plot against the fire chiefs. So I told Kathy, I said, we need to stop there first, because if you don't get the people in the field, the people with the technical expert that are doing this job out there on our side early on, this is going to fail. So as you know, the state is running this pilot study, and there's all these different options that you could choose to do, right, to serve the community. So I looked at it and I thought, alternate destination. Again, slam dunk, we can do this. The guys and the ladies in the field are very technical. The training, all that has gone smoothly for us. But fortunately, we got them on board early on. And then we reached out and said, who else do we need? So we had to reach out to the hospital networks and get them. And we weren't trying to bypass the ED areas and the doctors and the nurses that work there, but we went to the top, because we figured if we can get them on board and kind of trickle this back down, because we're going to get opposition from the bottom, as we found out at some of our public hearings, right? That people are going to oppose this because some of them don't understand what we're trying to do. But that was another critical component for us, was to get the people, the executive level people, on board with what we're trying to do in the field. And then the research part of it. We didn't want to go through all this and not be able to actually put something on paper and say, this is what we did. Look what Orange County did, right? So we reached out to UCI and we made partners with them. Another critical component to this, because the technical expertise that comes out of that group was invaluable. And then we had to build this steering committee and bring all these technical experts together and get them moving in the right direction. And that's why it allows me to be the chair, because I'm not the technical expert. But I have folks like some of the people that are sitting in this group right now as part of my team. So that was brilliant, to bring all these people together into one room and then form this group and get them to go out and do things. And everybody take a little chunk of this and bring it together, because that's the other issue. We just came off the recession. Everybody's scaled back. I have a staff of one, and you're looking at them. And there's no way that I'm going to be able to put all this effort into this pilot study and make it happen. I needed partners. I needed people that are highly committed and care about the way we deliver business or care to people in the field. So you had to bring all these other technical experts in. And when you do that, our steering committee consists of about 15 to 20 people. And they're committed people. And they come to the monthly meetings, or they answer the calls or the emails. And a lot of times I see one of our members in here is actually responding and doing things from trips when she was in Israel. So significant commitment level to the steering committee. And if you don't have those people that are going to be part of that, you're kind of setting yourself up for failure. So that was probably one of the things that we did the best, was to make that steering committee and make it very strong. Funding was another issue. Money always comes into it at some point, right? I already mentioned the IRB data collection. Data collection is easy on the front that it's there, but now you got to go mine it, and you got to figure out how to pull it out of EPCR. And I don't know about you guys, but we just started that about a year ago, so we're still kind of working through some of that. But Dr. Miller has done a great job of building different ways to mine that information and get that information for us. And then what about the information that we don't technically own, that the hospitals have, or that maybe some of the insurance companies hold? Everybody thinks this is a great idea, but nobody wants to give up their secrets. So that's been a little bit of a challenge for us as well. The 1 minute sign went up about 2 minutes ago, so I think I'll just hold it at that. But I would like to just close with saying, when we started this whole thing, one of the reasons the fire service is a great partner in this, because we're so entrenched in the community already. We just have to get us going in the right direction with all our other community partners. And I figured that if we can get the fire service, which is an organization that's probably more traditional than the Catholic Church, to kind of open up their eyes and really consider the way we do business today might not be the way we're going to do business tomorrow, it's going to be a great success. So I think we can do it, and I look forward to it.
Good morning. My name is Richard Murdoch. I'm the executive director with Stanislaus County. Actually, we are Mountain Valley EMS agency. We're a 5-county regional EMS agency. And our pilot project study, we're pilot project number 12, have some of the following objectives. And our primary objective is to reduce utilization of emergency room services that are held by behavioral health patients that normally would have been transported to an emergency room. And we accomplish this by demonstrating appropriate utilization of non-traditional alternate destinations for behavioral health patients that are assessed and are treated by a community paramedic. And obviously this is under the direction of our local EMS agency medical director, Dr. Mackey, where a community paramedic would perform a medical screening examination, and if the patient is medically cleared, they would transport that patient to a behavioral health center. And so it's really aimed at reducing hospital and EMS system costs, reducing emergency room overcrowding, thereby allowing for a more efficient use of emergency department resources and reducing any secondary transfers between the emergency room and a behavioral health center. Barriers, I can spend probably most of my time here. Our major barrier that we are dealing with has to do with an EMTALA issue. And the reason it's an EMTALA issue is because we have 2 campuses under 1 license. We have Doctors Medical Center in Stanislaus County in Modesto, and we have Doctors Behavioral Health Center, and they're licensed both under tenants license, basically making Doctors Behavioral Health Center a doctor's office. So Centers for Medicare and Medicaid Services considers that an acute psychiatric illness to fall under EMTALA laws and obligations. Therefore, anyone that presents with an acute psych condition to the Behavioral Health Center must receive a medical screening examination by a physician. So Doctors Behavioral Health Center's current practice is to transfer all of these patients to Doctors Medical Center ER for a medical screening examination, and then they take the patient back to the Behavioral Health Center. And this is roughly probably 5 to 8 miles apart the campuses are located. So CMS indicated that because Doctors Behavioral Health Center is an EMTALA required facility, the patients in our study will require this medical screening examination, and there's no way around it. So our options currently, and this all came about within the last several months, and so this is a major issue that we're dealing with. So the options is Doctors Medical Center is discussing credentialing the community paramedic to provide the MSE under their license. That's one option. We haven't reached fruition with that yet. We're still in discussion with the hospital. The second option is that Doctors Medical Center hires a physician to staff the Behavioral Health Center during after hours to provide the MSE. And that's an option that we're really entertaining, because the data that we have, the preliminary data from our other participating hospital, states that if we divert 30 patients per month, which is approximately 100 eligible patients as identified in our baseline data, it's estimated $7,600 charges per visit by the emergency room, which is roughly $2.7 million per year. So that's kind of our motivation to move forward with this on second option. The third option that came up was to transport all potential pilot study patients to Doctors Medical Center first for a brief medical screening examination and registration, and then transfer them back over to Doctors Behavioral Health Center. But then that is really counterproductive to the goals of our pilot project study, because then we would be transporting all of these patients that fall out as psych patients to the emergency room, evaluated, then to the Behavioral Health Center, and that's what we're currently doing. 1 minute. Uh-oh, this is going to be tough. So the second piece is we've had a couple of changes early on with regards to eliminating a consultant that we initially used. And this has to do with baseline data. And it really wasn't clear that our study was to track patient-level data, that is, following the patients through the system. The patient pool data that was initially written was way too broad. And we had several hundred patients falling out on a monthly basis that were transported to our participating hospitals. So we discovered this about 2.5 weeks ago. And it included anyone listed by the pre-hospital crew as a psych patient on the patient care report. So it could be a chest pain with anxiety on a secondary impression. It would fall out as a psych patient. So approximately 2 weeks ago, we had several, actually we've had several phone conversations with UCSF and Lou, and our QI coordinator basically rewrote the patient population criteria to only include patients that would truly be part of our focus, and it's now roughly about 100 a month that are falling out. That would be 5150s, manic, a patient that's having a manic episode, a danger to self or other, or suicide. We reran the data points for UCSF, and then we provided all of the hospitals that participate in our study with a list of patients that we transport to their facilities and asked them to rerun their data points for each patient. And that basically was for the primary disposition. So with that, we're just kind of waiting to see what happens with the data, and hopefully we'll be able to move through this project. But again, our major issue that we're dealing with is this EMTALA issue with the hospital. So with that, I think I'm past my time, and thank you very much.